We're going to be joined by Dr. M, who is a dual board certified dermatologist and Mohs surgeon in Canada and the US. She graduated in the top 10% of her class at McGill University, where she also completed her dermatology residency and was awarded the Residence Teaching Award. She completed an American College of Mohs Surgeons accredited fellowship at the University of Toronto and now practices at the Skin Clinic in Toronto, specialising in Mohs micrographic surgery for non-melanoma skin cancer and facial reconstruction. I do want to give a small trigger warning before Dr. M starts her presentation, as she will be sharing some graphic images. Please do reach out to us for support after the webinar if you find these cause you any distress. So I'm going to stop sharing my screen and hand over to Dr. M.
All right. Thank you so much for that kind introduction. Before I begin, I just wanted to give you guys a little bit of background of the work I do. I work as Emer mentioned at the Carlton Skin Clinic, which is located in Toronto, and I work with the best group of people. So we're a group of Mohs micrographic surgeon, a plastic surgeon, and a lot of staff that support our work, lab staff, nursing staff, and we really specialize in non-melanoma skin cancer, particularly on the head and neck, and we do also wide local excisions on the body. And I'll go over what this means later on. And we try to provide our patients collaborative care and actually do have patients from across Canada. So we're happy to help if you ever need it. So let's get started. The outline of my talk tonight will be definition, so just getting us all on the same page. We're going to talk about how common are these skin cancers? Are the rates increasing or decreasing? Where do they occur on the body? Who are they affecting? And what do they look like? And what are the treatment options? So, what are non-melanoma skin cancers or NMSC? It's actually just an umbrella term for every other skin cancer other than melanoma, and this happens to be made up of primarily basal cell carcinoma or BCC and squamous cell carcinoma, SCC. There are some other rare tumors like atypical fibroxanthoma, which is referred to as AFX, or microcystic adenocarcinoma, which is referred to as MAC, but these are really rare, so we're going to really focus on the first two. How common are BCCs and SCCs? They're the most common cancer in Canada and definitely the most common skin cancer. The good news is that the majority are very easily treatable in an office setting. So we actually don't have a Canada registry that tracks how many we actually have, but we do have some data to guide us with these numbers. In 2014, the Canadian government looked at non-melanoma skin cancer and they found to have 76,000 just in that year alone. And of these cases, 78% about were basal cell carcinoma. So basal cell is more common than squamous cell carcinoma, which only made up 22% of cases. That translated to a lifetime risk that they calculated for basal cell carcinoma to be 1 in 8. So this is Canadian data. Out of 8 Canadians, 1 Canadian during their lifetime may develop a basal cell. And for squamous cell carcinoma, it's 1 in 20 Canadians. And what's happening to these non-melanoma skin cancer? Are they increasing or decreasing? So we have some data. The most recent study comes out of Ontario. It's published by Dr. Chan at Women's College in 2021. And he showed that initially the incidence, so the frequency they were occurring was decreasing until about 2003. And since then, there's been a steady increase. And they calculated the increase to be about 30%. So they're still very common, very relevant discussion to have. Who gets non-melanoma skin cancer? So it affects men slightly more than women, of a ratio of 1.5 to 2 to every 1 woman. It's increasing in incidence with age. So the older we live, the higher chance we are to develop them. And this same Ontario study showed that the highest incident were males over the age of 50. So now let's talk about mortality and morbidity, meaning why do we care about these? So for basal cell carcinoma, they rarely metastasize, meaning they rarely ever spread to lymph nodes or organs. So it has a very low mortality, which is very good for patients. However, they can have high morbidity. They can really impact on function or quality of life. So just some warnings, some clinical images will be coming. I'll try to give you guys warnings before I show any images. So this is a small basal cell carcinoma, and this doesn't spread. However, it's occurring in a very important anatomical location. It's the lower eyelid and covering somebody's lacrimal duct. So having something grow in that area can really impact not only function, but also cosmetic outcomes too for the patient. This is another basal cell carcinoma that occurs on the nose of a patient. And you can see there's some hemorrhagic crest, which just means some dried blood. So it's growing and bleeding in a very important area. What about squamous cell carcinoma? They have a local reoccurrence rate about 3%, so the chance of it coming back to where it was treated. Their chance of it spreading to lymph nodes is about 4%. And the chance of somebody actually dying from this disease is 1.5%. So it's very low. However, there are certain high-risk subsets where metastatic squamous cell carcinoma can really have a high mortality. So this is just to emphasize that it's really important that we try to catch and treat these squamous cells and basal cells as early as we can. So just some warning of a clinical image coming. So this is a patient that had a very large squamous cell carcinoma, which is not pictured here, but I did include a picture of a lymph node. So that's this firm lump over their clavicle bone. And that's was the squamous cell carcinoma spreading to that lymph node. Where does it occur? It most often occurs on the head and neck area, but they can occur anywhere on the body. And now let's talk about why do we get them. So we'll start off with basal cells. There's three main categories. The first is genetic, and that is your pigmentary phenotype, which refers to having fair skin, always burning in the sun, freckling, having red hair. There are certain syndromes, such as basal cell Nevis syndrome, or what was previously called Gorlin, that predisposes patients to basal cell, and they often are diagnosed before the age of 20. Environmental exposure is very important to discuss because that's something that we can have some sort of control over. So UV exposure, which we'll go over into more detail, predisposes to basal cell carcinoma. Ionizing radiation that is can be found in imaging like CT scans. So what is often the clinical scenario is that a patient may have had many CT scans throughout their life, and this radiation could predispose to basal cell. The good news is that the technology has really advanced, and the ionizing radiation released by modern day imaging devices has very low ionizing radiation, so it's less important risk factor. Chemical exposure is usually through occupational, so through somebody's work. Arsenic, coal tar, soot, nitrogen mustard, polychlorinated biphenyls, and 4x4 bipyridyls. Those are all usually found in certain occupations, like working with pesticides would be a common exposure. And the last category is immunosuppression, particularly patients that have had an organ transplant. They are more predisposed to basal cell carcinomas. What about for squamous cell carcinomas? So you'll see here the risks are very similar. So the same genetic risk factors. The syndromes are slightly different, but these ones are very rare. So albinism and xeroderma pigmentosa. Environmental exposures are very similar. The unique ones to squamous cell carcinoma is the human papillomavirus, or HPV. Certain strains can predispose to squamous cell carcinoma. Cigarette smoking is a risk factor, immunosuppression, as we previously discussed. And there are some very rare clinical scenarios where, for example, a patient with a chronic, not healing wound, I've often seen leg wounds, they can develop squamous cell carcinoma in those wounds. Long-standing rashes like discoid lupus erythematosus, lichen planus, or lichen sclerosis, particularly if not treated, can the patients can develop squamous cell in those rashes and porokeratosis. Often these are really rare diagnoses. More common we see is like UV exposure and of course genetic factors. So let's take a moment to talk about UV exposure. I think it's really important to talk about because that's something we can't control. We can't control our genetics for now, but our sun exposure we can try to control. So basal cell carcinoma are known to be formed due to intermittent intense UV exposure. And I think this is really relevant for Canada because we have many months of the year where we don't have a lot of UV. But then in the summers, the UV exposure is very intense, or we often travel down south and go to sunny destinations. Sunburns, as well as a risk factor for basal cells, particularly before the age of 20, so in the younger years. For squamous cell carcinoma, the risk factors tend to be cumulative intense UV exposure. So there was a study from California where they have constant sun throughout the year, and they actually have almost as many squamous cells as basal cells. And sunburns as well will predispose to squamous cell carcinoma. And of course, I can't not mention tanning beds. Tanning beds, there's no safe use of them. They've been shown to increase the risk of squamous cell carcinoma by 2.5-fold and basal cell carcinoma by 1.5-fold, and of course, melanoma, we know. So, how are these skin cancers diagnosed? So, it's often a clinical exam, meaning you see your practitioner and they'll often do a skin exam. This is a cartoon that I made of somebody getting a skin exam, but ideally, your practitioner will look at your body and examine the lesions, and they have very suggestive features of how they look. Often you may see your practitioner use a dermatoscope. So that's this tool pictured here below. It magnifies by tenfold, and there's certain features on dermoscopy that are very suggestive for skin cancer. So how do they look like? We'll first start off with basal cell carcinoma. We'll go over the different subtypes. This is the nodular subtype. Often patients will tell me, I have this pimple that's growing, bleeding, and it's just not going away. And in this case, it's a basal cell. This is another example of the nodular subtype. And in our textbooks, it's often described as having a pearly appearance, which describes how the light reflects from it. You can see in this picture, the light is really gleaning off the lesion. The next subtype is the pigmented. These ones can be brown or black in color, and they really stand out. And I find patients will seek care very fast for these because they're worried about melanomas, but it's actually a basal cell. This is the superficial subtype of basal cell. And the clinical story patients tell me is like, I had eczema or psoriasis, and I thought it was just that. And I tried to use my creams, but it never really went away. And then they finally sought an opinion and they were found to have superficial basal cell. The last subtype is the sclerosing or morphiiform basal cell. And I find this one to be the trickiest to diagnose because it really looks just like a scar. And I really trust my patient's history on this because they'll tell me, I never had a trauma in this area. Nothing's ever happened. And they just suddenly develop that scar. So it really makes me think twice about these lesions. And they're clinically a little bit trickier to treat too because it's hard for us to tell where do they start and where do they end. Now, what about squamous cells? There's not as many clinical subtypes. Um, these are two classic squamous cell carcinomas. The key for them is they often grow faster than basal cells. Like patients will say, last month I had nothing, but now I have this lump growing really fast. And they tend to be more keratotic. And that just means it's more scaly. This is a subtype of a squamous cell. It's called a keratoacanthoma, a fancy word, but they look very distinctive because they look what it described to be as a volcano-like appearance with almost like a crater in the middle. They actually have a better prognosis, and there's been reports of them even clearing by themselves without treatment. So next step for the diagnosis, your practitioner has done the exam, maybe they've used a dermatoscope. How do they confirm what it is? What can be done next is a biopsy. There's many ways to do a biopsies. I'm just showing you a picture of one way. This is called a punch biopsy. So there would be local freezing to the area, and then a small sample is taken and sent to an external laboratory. The results, depending on the province you're in, can take from 2 weeks to 4 or 6 weeks. Now let's talk about the different treatments. So you have biopsy result and it shows that it was a non-melanoma skin cancer. The treatment's really divided if it's low risk or high risk. So low risk lesions are ones that are small on the trunk and there's certain histological subtypes. So what is read on the pathology report features of that can determine if it's low risk. So for low risk subtypes, one of the treatments that can be done is called curettage and electrodesiccation. So that's also done at a local office, local freezing to the area. A curette is used, so this is this tool here, and electrodesiccation, which kind of burns the blood vessels. Next treatment option is cryotherapy. That's using liquid nitrogen, which is very cold, and it essentially causes very much like a ice burn. Creams are also an option. These are topical chemotherapy creams, and they work by finding these skin cancer cells and really destroy them. So while you're using the creams, they can cause quite a significant reaction to the area. Lots of redness, burning, and peeling. And there's two usually that are mainly used. They're 5-fluorouracil, and that's used in conjunction with calcipotriol sometimes, and imiquimod. And they have a lot of different brand names. The last treatment option that you can consider is photodynamic therapy. There's not a lot of coverage across Canada for this, but it's a very interesting treatment because a cream is applied to the skin cancer. And then when a patient is exposed to a certain light, it could be a laser or a blue light or even a red light, the cream gets activated and will only destroy those cancer cells in that area. So how do you decide which treatment is the best? Well, there's many factors and it's obviously a discussion with your practitioner, but there's patient factors, your preference for duration of treatment, the side effects. There's tumor factors, the size, the subtype, and the cost of the treatment and what is covered by the province. The cure rates is something that I'm always asked about. So if these treatments are used in the correct tumor, so in these low risk ones, the cure rates are really high. So EDNC has a cure rate of 92, cryotherapy of 93. Some of the creams can have cure rates of up to 90%, and photodynamic therapy, 93%. But just take those numbers with a grain of salt because these studies were done in the perfect scenario in these really low risk ones. So what about for high risk tumors? So those are the ones on the head and neck, certain pathological subtypes, and larger lesion. Radiation is a treatment option, and that's usually done in a hospital setting. You see a radiation oncologist and usually have multiple sessions to treat it. Wide local excision is usually done in a local outpatient office. It's where the practitioner will take 4 to 6 millimeter margins of extra skin around the tumor and surgically excise it. And then the next option is Mohs micrographic surgery. There's more variable access to it in Canada for it, but it is mostly available in most major centers. Um, and I just wanted to show you guys this video of it because it's more of a visual representation of what we do.
Mohs surgery significantly reduces damage to the surrounding tissue while effectively removing all traces of cancer. First, your fellowship-trained Mohs surgeon marks the tumor with a pen. While there is no need for the patient to undergo general anesthesia, patient comfort is a priority. So before the Mohs surgery procedure begins, the affected area is numbed with a local anesthetic. Then the surgeon excises a saucer-shaped piece of tissue with 1 to 2 millimeter margins around and below the marked border. Patch marks are made on the skin to maintain specimen orientation. A bandage is placed over the patient's surgical site, and he or she will wait comfortably while the excised tissue is taken to an on-site lab where it's prepared for microscopic evaluation. Many Mohs procedures can be completed in several hours, but some cases will take longer. Your fellowship-trained Mohs surgeon, who has training in skin pathology, carefully examines the tissue under a microscope to see if the cancer has been completely removed. If residual tumor is found, it's marked precisely on the map. A second Mohs layer is excised only in the positive area. This process is repeated until all the margins are free of tumor. Your fellowship-trained Mohs surgeon will explain the most effective means of surgical site closure and postoperative care at the time of your procedure. Small, simple wounds in appropriate areas are allowed to heal naturally by a process known as second intention. Most wounds are closed with a linear repair, a side-to-side stitching of the surgical site. To close a circular wound, extra tissue on either side of the circle is trimmed so that the suture line lies flat. Larger or more complicated wounds may require skin grafts or a flap, which closes the surgical site by moving adjacent looser skin to fill in the wound. There will be some scarring once the area is healed, although scars from Mohs surgery are often smaller and less visible than those from other excision procedures. As a member of the American College of Mohs Surgery, your Mohs surgeon has undergone residency training in dermatology prior to a rigorous 1 to 2 year fellowship in Mohs micrographic surgery and dermatologic oncology, during which he or she performs more than 500 cases. These cases not only include the pathologic interpretation of both common and unusual tumors, but also performing routine and complex reconstruction. Our primary goal in performing Mohs surgery is to cure your skin cancer and to preserve normal tissue. Compared to other skin cancer treatments, Mohs surgery has a very high success rate, up to 99%. You can trust the hands of a fellowship-trained Mohs surgeon to give you the optimal result.
So that was a very good video from the College of Mohs Surgery. They're probably a little bit biased, but they're right. Mohs does offer the highest cure rate. Despite the Mohs micrographic surgery cure rate being 95 to 99%, the other treatment options are also really high cure rates of 91% of radiation, wide local excision of 90%. So there's really high cure rates for all the treatment options. So I'd like to just give you another warning. There's going to be some graphic images. So this is a Mohs defect, so it's surgically removed and it's stitched up a linear, this is called a linear closure, and you can see the cosmetic outcome is really good. This is one of my colleague's patients that had a large squamous cell on the temple. She did a combination closure of a flap, which means moving skin over, and a graft. And you could see here at 3 months, they have very good outcomes. So what about for patients that have unresectable or metastatic disease? So when the tumors have spread, we have treatment options for that as well. So for basal cell, there's two medications, vismodegib or sonidegib. They're oral pills that can be given for metastatic or unresectable basal cell. And there's off-label use of immunotherapy. And then for squamous cell carcinoma, there is now an immunotherapy medication approved by Health Canada, which activates a patient's own immune system to try to treat these squamous cell carcinomas. And this is the pictures from their clinical trials showing that they have very good results. So this patient had a lot of metastatic disease, and after treatment, they have most of their tumors are all gone. So it's really exciting and hopeful time to treat these patients because I think we really do have a wide variety of different treatment options. So in summary, we discussed that non-melanoma skin cancer are mostly basal cell carcinomas and squamous cell carcinomas. Basal cells and squamous cells are the most common skin cancers and cancers in Canada, and we discussed they are increasing in incidence. Risk factors are genetic, environment, and immunosuppression. And sun safety is an important modifiable risk factor. So trying to practice sun exposure safely. There are various treatment options for both low risk and high risk disease, all with excellent outcomes. So I'm really glad that you all shared your evening with me, and I'd like to thank Melanoma Canada for having me tonight.
So thank you so much, Dr. M, for that very informative and educational presentation. And I just want to finish off the presentation by highlighting some of our support services. We do offer email and phone support. We're available Monday to Friday, 9 to 5 Eastern Time. We will share the contact details at the end of the webinar for anyone looking to avail of our services. We do also offer cancer coaching, which is a one-to-one support service offered to melanoma and skin cancer patients and caregivers. The support is offered over the phone or online. These services allow clients the opportunity to talk through their experience in a safe, confidential space with a cancer coach. And these sessions are completely free to all clients. We also run a melanoma and skin cancer support group twice a month, the first and the third Wednesday of every month at 6:30 Eastern Time, allowing patients to connect. We do have a peer-to-peer support program. This program is where we try to match patients with other patients of a similar diagnosis, similar treatment plan, similar age, or similar province. The program allows patients to connect with each other via email or phone and gives new patients the reassurance that there's someone who has already been through a similar journey to them and they're ready to walk along beside them. We do have a very active online community, and we have private Facebook groups for basal cell and squamous cell patients and caregivers. We often share our patient stories on our website and social media channels. And if anyone would like to reach us on Facebook or Instagram, for example, you can find us at Melanoma Canada. Finally, we have a lot of publications that have been written with the help of specialists in oncology and dermatology and are useful for melanoma and skin cancer patients, caregivers, and healthcare professionals.